All right. So again, welcome to today's event on Skilled Nursing Facility MDS Section O Issues and Findings. My name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education Department, and I'm joined today by other members of Provider Outreach and Education, as well as Medical Review, who will be assisting me if we have questions in the question and answer portion of today's webinar. Now, on October 1st, 2023, the new MDS 3.0 became effective and presented some major changes to many sections and revised coding procedures. Now, with our ongoing 5-claim SNF reviews of every facility, our medical review staff continues to identify issues in some of the major sections of the MDS that can affect payment reimbursement. The intent of the items in Section O is to identify any special treatments, procedures, and programs that the resident received or performed during the specific time period. So in today's webinar, we're going to focus on how the identification of these items or not identifying these items can lead to inappropriate coding on your skilled nursing facility claims. On the screen and in your slide deck is our disclaimer slide. And in a nutshell, our disclaimer said we prepared the education today as a tool to assist our provider community. And we did that using the most current laws, rules, and regulations as they are today. If those laws, rules, and regulations happen to change tomorrow, it's your responsibility as a provider to make sure you are complying and following any Medicare laws, rules, and regulations that are in place on your date of service. We're going to provide responses today on the laws, rules, and regulations as they stand today. Now, CMS does prohibit the recording of our presentation for profit-making purposes. So if you happen to be recording or taking screenshots of various slides, we ask that you stop doing so. We are recording this for you, and again, it will be on our YouTube as an encore of today's event. This is a list of various acronyms that are in most of our skilled nursing facility educational events. So if I happen to use one of these acronyms and you don't know what it is, you can refer back to this slide. All right, my objective for today is that you learn about the identified issues in Section O of the MDS that can lead to your skilled nursing facility claim being recoded into a different PDPM payment. We're going to achieve this today by reviewing the Medicare drivers of payment for Section O. We're going to highlight the importance of accuracy of capturing special treatments, procedures, and programs on admission and while the patient is a resident. And we're going to discuss isolation and what must be contained in the documentation. So let's just kind of review what changed in Section O in 2023. So Section O identifies any special treatments, procedures, programs received or performed during a specific assessment period. The language "or performed" is a new addition to MDS 3.0 that happened in that October 2023 change. So facilities can now code treatments, programs, and procedures that the resident perform themselves independently or after setup by the facility staff. Another change that came about in the October 2023 changes included the removal of "while not a resident" column and the admission, like on admission and at discharge, those two columns were added. We're going to talk about more about these in a little bit. Another change was a change to the O0250 influenza vaccine to include a reference for when facilities must offer residency influenza vaccine, and some clarifications for section O0400 therapies and the O0425 Part A therapies. There were some clarifications made that were added for the interrupted stay. So you're going to want to refer to the most recent MDS 3.0 RAI manual to ensure that you're complying with those correctly. With Section O changes, facilities need to review the resident's medical record to determine if they received or performed any of the treatments, procedures, or programs within those assessment periods defined for each column. We're finding that some facilities are still not accurately capturing these. Poor documentation will lead to poor coding and poor reimbursement. So your MDS coordinators will look closely into nursing documentation to code these treatments. So really make sure that documentation supports and has that detailed, accurate, and timeliness that your facility MDS coordinators need to complete those sections appropriately. So again, the purpose of today's webinar is to review the findings in the MDS Section O and to help you avoid some of those. All right, again, to reiterate, the intent of Section O is identify any special treatments, procedures, programs that the resident received or performed on their own during those specified time periods. So on the last slide, we talked about how while not a resident was removed and the categories were changed. They were changed to on admission, while a resident, and at discharge. And the time periods for each of these are as follows. So on admission refers to the time period of days 1 through 3 of the SNF PPS stay. And while a resident refers to the time period after admission or entry or re-entry to the facility and within the last 14 days. At discharge then refers to the time period in the last 3 days of the SNF PPS stay. So capturing special treatments and procedures and programs. Make sure you review the resident's medical record to determine whether or not the resident received or performed any of the treatments, procedures, or programs within those defined assessment periods for each of those columns. You can code these if a resident performed them themselves independently or after setup. Remember, that was a new change in October, but we're still seeing some issues with that. You would not code services provided solely in conjunction with a surgical procedure or a diagnostic procedure, such as IV medications or ventilators or surgical things, including like routine pre and post-operative procedures. Those would not be included. So as we move on in the presentation, let's break down these periods just a little bit more and talk about them just a little bit more. So on admission, check all treatments, procedures, programs received by, performed on, participated in by the resident. Make sure that's in that in days 1 through 3 of the SNF PPS stay. And that starts with A2400B. And that's the start of the most recent Medicare stay. If no treatments or procedures or programs were received or performed in the 3-day assessment period, then you're going to check Z, none of the above. Same with while a resident. So if you remember, the old category used to be while not a resident. And we still have some reviews that are still coding incorrectly. While a resident refers to all treatments, procedures, programs that the resident received or performed after admission or entry or reentry to the SNF and within the last 14 days. And then again, if none of those were done, then you would again check Z for none of the above. And then discharge, finally. So when coding at discharge column, be sure to code all treatments, procedures, and programs. Again, that's in the last 3 days of the SNF PPS stay. And that's ending with A2400C, which is the most recent end date of the Medicare stay. And then again, if those weren't pertinent, then you would check Z to none of the above. And I think the category is listed as like Z1 for none of the above. Now, the prior two, the on admission and while a resident, those, when we go into looking at the sample MDS, those are categories that drive payment. The at discharge is not as much affected, but the first two categories are. Isolation or quarantine for active infection or diseases in the last 14 days. And we're going to talk about this, or we're talking about this separately, because isolation or quarantine was a big one coming out of the end of the public health emergency, and one that we see often still gets coded incorrectly. So as the RAI manual states, isolation or quarantine for active infectious diseases does not include standard body or fluid precautions. So you code this when the resident requires transmission-based precautions and single room isolation. So that's alone in a separate room because of an active infection. So, for example, symptomatic and/or have a positive test and they are in a contagious stage. And that also is an infection that is highly transmittable. Epidemiologically significant pathogens have been identified, and those could be acquired by physical contact, airborne, or droplet. Do not code this item if the resident only has a history of infectious disease. Like, for example, their status post MRSA or VRE or status post C. diff, and there's no more active symptoms. Do not code the item if the precautions are standard precautions, because these type of precautions apply to everyone. So standard precautions include hand washing, hand hygiene compliance, glove use, may additionally include like masks or eye protection and gowns. Some examples of when isolation criteria would not apply include urinary tract infections, encapsulated pneumonia, and even wound infections. So as a provider, you would code for single room isolation only when all of the following criteria are met. And those are listed here on this slide, but we're going to go over them as well. So the resident has an active infection, highly transmittable, or epidemiologically significant pathogens that have been acquired by physical contact, airborne, or droplet transmission. The second is precautions are over and above standard precautions. That's an important one. That is like transmission-based precautions, so contact, droplet, and/or airborne must be in effect. The resident is in a room alone because of active infection and cannot have roommates. This means that the resident must be in the room alone, cannot cohort with a roommate, regardless of whether the roommate has a similar type of active infection or requires isolation. The resident must remain in their room. This requires that all services be brought to the resident. So if they need rehabilitation activities, dining, etc., all that comes to them. They don't go to it. So most often missed in the documentation is the information supporting that the patient was quarantined to a single room during the isolation period, and that the staff took isolation precautions when entering the room. We've seen instances where isolation was coded, and the documentation supports that the person has been in the dining room, or that visitors such as family members have been coming in and out of the room, coming or going, or that the person is not confined to a single room. If those things exist in the documentation and we do not see anywhere within the documentation that quarantine has ended or that active infection has been resolved, then we're most likely going to recode the claim and remove that from Section O of your MDS. If that isolation period has ended, please note that in your documentation and note that it has ended. When you're submitting documentation, and isolation has been marked on your MDS, you must support that in the documentation that you send to us. And it must support that all that isolation criteria that we talked about have been met. And if the dates of service that are under review are after the time the isolation has ended, you must still provide that information regarding the isolation as well as when it ended in your documentation that you submit for medical review. If we don't have that, we can't in good faith say you followed all the rules and that the isolation was coded appropriately. So then your only hope would be to hopefully submit for an appeal if you have the documentation that supports it. So remember, on first go round of medical review, make sure you give us that information that accurately supports it, and if it has ended, the documentation that supports when that ended. All right, so a few tips for capturing information accurately. To help ensure your admission team is accurately capturing the on-admission information, as a facility, you may want to consider creating a standard request for information. So a form and a procedure that can be used to get information from the hospital, to get information from your care teams, and to complete your admission documentation. So make sure it contains the specific language on treatments provided, treatments completed, what patients can and can't do for treatments and procedures on their own. Ensure that your nursing documentation is very specific and detailed to assist in this coding. Often the nursing documentation that we receive only includes check boxes, which does not provide evidence to support the coding on the MDS in most cases. Finally, ensure that any information regarding special treatments or procedures and programs reviewed or performed during the stay that were not previously identified on admission are shared with the nurse coordinator. So it can be properly coded on the MDS as something that is while a resident. All right, so as we move on, and if you've participated in the last couple of webinars, I've brought up this Briggs MDS sample. So on your screen and in the slide deck and in the chat, Jennifer also put a link to this. I like to use this sample in training because they highlight the areas with Medicare required information, which makes it really easy to see what areas affect Medicare drivers of payment. I'm going to just go ahead and go out to this, and you can use the link on the slide at a later date and time, or the link that Jennifer put in the chat. And I'm going to show you their sample. Now, I have this up. All right. So on your screen is the sample Briggs version of the MDS 3.0. And again, this is just a sample. You can see there's a watermark. It's marked as such. I'm not promoting it. I have no vested interest in this company, etc. I just like the way they have included the Medicare indicators, and it makes it nice and easy for you as a provider to see what those are. So starting on the first page of this sample, you'll notice at the top of this sample, there's these green indicators. And I know it's a little small. I will put this a little bit bigger on the screen. Hopefully you can see that. Okay, so the little green money bag that indicates that section affects PDPM payment. So the general green outline and the green hexagon indicate SNF quality reporting measure programs. I'm going to scroll down to section O, and actually I'm just going to link to it because I know it starts on page 36 of this example. All right. So again, as we've mentioned already, Section O is another big one for payment. We kind of in this last couple of weeks hit on the big three, Section GG, Section I, and today's Section O. And again, as a reminder for today's purposes, we're focusing on those drivers for Medicare payment in these sections. So in Section O, you can see all of these things where the green outline and the green money bags exist. As we scroll down through section O0110, which is this one that we're on right now, you're going to notice all these different things that affect drivers and payment and PDPM. So chemo, IV chemo, radiation. We have oxygen, especially continuous oxygen. Some are on admission and while a resident, others are just on admission. As we continue to scroll down, suctioning, trach care, as well as scheduled and as needed suctioning could affect your payments. Invasive mechanical ventilator or respirator. IV medications, we'll talk about those in a little bit as well. Dialysis, hemodialysis, peritoneal dialysis, and then isolation or quarantine while a resident. So as we continue to scroll down, see we're going to go through the therapy sections, which do not have green around them. And we're going to go down to respiratory therapy. And the amount of respiratory therapy that was administered in the last 7 days. And then again, scrolling down more through some of the therapy stuff, we get to the restorative nursing program information. So again, here, under the restorative nursing and the number of days, make sure you're paying attention to the time frames that are identified in the MDS as well. So these have restrictions on how many minutes a day and in the last 7 calendar days when capturing those. As I discussed on other PDPM, the focus and driving factors of Medicare payment for PDPM is on the patient themselves and their abilities, not the therapy or the minutes. So as we go back up here, you can see how that stuff is no longer green, no longer listed as a driver. That is why you see, again, that's no longer listed. They are important sections to complete, but they're not drivers of payment, because PDPM focuses on the clinically relevant factors instead of the volume-based services, which is why payment accuracy for each patient is made for their unique needs. This now allows the daily reimbursement rate for the individual patient-based information using their classification and their anticipated resource needs during the stay. So let's face it, the RUG category did not focus much on patient outcomes, only that they were receiving therapy. It's been long noted upon review that patients often receive therapies that were not needed or were not needed for the length of time they were received in an effort to drive up reimbursement. Now with PDPM, multidisciplinary models, they can identify what the patient needs most for their personal care. And really in the end of it all, PDPM allows the reimbursement only for what's needed and only for what's rendered. So if you're following along in the slide deck, the next slide you would see would be for the documentation review. And I am going to bring up the documentation review and bring that over to your screen. Jennifer, can you verify that the PDF is showing on your screen?
Yes, it is.
Perfect, thank you. So again, if you're following along with the slide deck, you're only going to see the slide that simply says documentation review. So in the interest of time, I do want to share some examples of Section O documentation and the review findings. And I'm doing this in an effort to assist you with making sure you are documenting to support the coding of the MDS. So in the first example, we're going to talk about IV medications. Now, this is information we know from the RAI manual. When it comes to IV medications, you're going to code any drug or biological given by intravenous push, epidural pump, or drip through a central or peripheral port in this item set. You do not code flushes to keep the IV access port patent, or KVO, keep vein open, or IV fluids without medication. Epidural, intracatheter, baclofen pumps may be coded here as they are similar to IV medications, or intrathecal, I'm sorry. And that they must be monitored frequently and they involve continuous administration of a substance. Let's see, subcutaneous pumps are not coded in this item. So do not include IV medications of any kind that were administered during dialysis or chemo. That's part of that treatment, and you would gather that in that information. Lactated ringers given IV is not considered a medication and should not be coded here. So resources and tools providing information on medications are available in that section of the RAI manual. So as I scroll down here in this example, we're going to get to the MDS that was submitted to us. So this is the actual documentation on this MDS. And you can see here that in their MDS on admission, they coded IV medications. So as I continue to scroll down, let's look at some of the documentation that we received from the chart. So one of the questions in their skin integrity, does the resident have IV access? And it was marked no. If we go down to information that was in a health status note, they say that the PICC line that the patient had was removed in the hospital. So we found no other information, no IV medication administration records to support any IV medications were provided either. In this case, we would remove the IV medications from the MDS because it was not supported. So this would need to be unchecked because it was not supported anywhere in the documentation, which could potentially change your payment rate. So we're going to scroll down just a little bit more, and we're going to look at another section of the same patient's MDS. And this is a good example. So I just want to point that out because it's easy for us to often point out what's bad, but we don't often always tell you what's good. So I wanted to show you a little bit of that as well. All right, so again, this is the same patient, and from the hospital information, just to kind of give you some background on this patient. So from the hospital information, we knew upon review that this patient has active VRE detected in the urine. They were in isolation in the hospital. They were receiving antibiotics, IV antibiotics through a PICC line. There were, they also were septic while they were in the hospital. And so things like the PICC line and other indwelling catheters, et cetera, were removed. And some of those were replaced while they were getting the infection stabilized. The PICC was one thing that was replaced, and antibiotics, fluids, et cetera, continued via that indwelling IV access. And then before the patient was discharged to the skilled nursing facility, that PICC line was again removed. Now, the MDS in this case was coded as we, scroll down here. And we're talking about isolation. So it was not coded for isolation. And in Z1, they had marked as such. All right. So then let's look at some of the documentation that was submitted. And I've kind of gone over this several times when we're talking about isolation and quarantine for infectious diseases. And you code this, and when these are in effect and the patient's in a single room, we talked about when to not code them. So if it has turned to standard precautions, if the patient's no longer symptomatic, et cetera. And then again, here's the single room information that we already went over on one of the previous slides. So knowing that the patient had come from a hospital in isolation manner, we want to see if these isolation precautions were still in place when they were in the SNF. Because although they didn't mark it, the patient had an active infection. So we want to make sure it's coded appropriately. So does the resident, what was the diagnosis regarding isolation? So they had some contact precautions due to VRE in the urine. Did they require some special precautions? Yes, because they still had some VRE in the urine. And then we had information about contact isolation precautions regarding the VRE in the urine, one time only until 10/2 of 23, which brought us into the SNF stay. The patient was on antibiotics for the VRE in the urine. So they had switched over. They were no longer on IV antibiotics. They were no longer in isolation. It was noted that the patient was not in a single room, requiring anything more than standard precautions for the infection, including urinary tract infections. So they did code that one appropriately by not capturing it. But had we found information that the patient was in a single room, was having more than standard precautions, was in isolation, we would have changed this for the provider, which then may potentially upcode what was reported on the MDS. And the facility would actually potentially get more payment than they requested. All right, so just so you know, it can go either way. It can be that, if we can't find something in the documentation, we may have to remove it from your MDS, and that may affect your reimbursement rate and may cause your claim to be down-coded or coded at a lesser level. But if we do find information and it is supported and we can capture it for you, we will do that, and you do have the potential to actually get more money from us. All right, so that's the end of our documentation review, and that takes us to the recap of today. So today we learned about those identified issues in Section O of the MDS that's going to lead to potential recoding into a different PDPM payment rate. And we achieved that today by reviewing those Medicare drivers, all those green sections in Section O that affect your payment. We highlighted the importance of accurately capturing those special treatments and procedures and programs, especially on admission and while the patient is a resident. And then we discussed isolation on its own and what must be contained, because we find that to be one of the biggest drivers of issues within our review findings. So at this time, I'm going to pause and check our chat, and I am not seeing any information or any questions that have come through in the chat. So in the interest of time, I'm going to go ahead and go into our closing remarks. But if you have a question, please place that in the chat, and I'll pause one more time before we close out today's event and answer those questions. And I just glanced over and there is nothing in the chat, so I'm going to go ahead and close. On behalf of myself, Jennifer and Rachel, as well as all provider outreach and education and medical review, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect. Have a great day.